Okay, so good afternoon, everybody. My name is Asaraya Warede, and I am a current member of the Johns Hopkins Science Policy Group. I want to thank you all so much for joining us today for our fourth seminar in the Stimulate the Vote seminar series. This seminar series is just one of a part of a broader initiative to unite the Johns Hopkins community in support of science prior to this upcoming election. So today's seminar will focus on healthcare and reproductive justice and features two fabulous speakers, Dr. Wangoy Morgai and Ms. Kimberly Haven. I just want to give a little bit of introduction to both speakers and then we'll get started. Dr. Morgai is a historian of medicine and science with a keen interest in the intersection of race and healthcare, as well as the politics of reproduction in the US. Dr. Morgai is currently Assistant Professor of African and African American Studies and History at Brandeis University. And Ms. Haven is a thought leader in the social justice movement with a special interest in reproductive justice issues facing incarcerated and formerly incarcerated women. She is currently the Director of Policy Advocacy and Outreach for From Prison Cell to PhD and Policy and Coalition Director for Reproductive Justice Inside. Our first speaker today will be Dr. Morgai, who will provide an overview of the history of reproductive injustices in the United States. And then following Dr. Morgai's presentation, we will proceed directly into Ms. Haven's presentation, who will focus more on the contemporary issues pertaining to reproductive justice and how these issues fit into the current political landscape. After both presentations, we will have a 30-minute Q&A discussion session where the speakers will address questions and topics that are of interest to all of you. So just to reiterate the logistics for this webinar, the chat feature should just be used to address technical problems, and any questions you have through the presentation, please submit them to the Q&A box. So without further ado, please welcome Dr. Morgai.
Thank you so much for that introduction and for inviting me. And for all of you who are attending this Friday afternoon, I have learned just a little bit about what this seminar is, and I think it's fantastic, the series of issues that you're discussing, and I'm so happy to be part of the conversation. So let me go ahead and share my screen. And as it was just mentioned, I'm a historian of science and medicine, and these are both fields that we tend to think of in terms of what they look like now, how medicine and science are practiced today, what scientists believe to be true, what they're working on in their laboratories to figure out. But both of these quests, the quest to better understand the world around us and the quest to understand our bodies and health, to know what makes us sick, how we can get better, these are pursuits that have long histories that have been marked by stunning successes and tragic failures. And we often think of illness as a biological event, something that goes awry in our bodies or in our minds, something that can be treated with pharmaceutical drugs. But being sick is also a deeply social experience, something that is shaped by our community, by our access to care, and especially in the US, by your race. And American medicine is not often examined from these, more historical, social, and political perspectives, but so much of what underlies medicine and what underlies science is personal and is political. And given the forum, and I know that there are a number of students and postdocs who are virtually attending, I wanted to start by sharing one example, one reflection that comes from a Dr. Fitzmullen, who was in medical school in the 1960s and active in the civil rights movement. And as a student, Mullen was reflecting on the kind of training he was getting in medical school, what was involved in entering this profession that's devoted to healing, the art and science of healing. And there were a number of questions that he really saw as political, despite the ways in which they might not typically be seen as such. Questions such as, who goes into medicine and why, right? Why do you choose to pursue that career? What happens to you when you do? What are medical students taught that is not strictly scientific or not strictly clinical? And what do they come to expect? What happens to medical students after they leave school and begin to practice their newly acquired skills? And importantly, what does this mean for the patients, for all of us who are being treated by these generations of practitioners? And I think that, bringing these questions, bringing a historical perspective is really important, because as a profession that's dedicated to healing those who are sick, medicine has a long history of social activism and political engagement, especially when it comes to struggles to provide and improve medical care to those who need it most and can afford it the least. Now, for our conversation today, I think it's helpful to begin with some of this broader context and to look at the history of healthcare in the US through the lens of reproductive justice and injustices of the past. And I'll start in the Jim Crow era, a period of US history that stretched from the 1870s to the 1950s, which through a series of federal and state laws worked to redefine Black Americans and other non-whites as second-class citizens. Through suppressing political and voting rights and laws mandating that there be separate spaces for whites and Blacks. So, for example, schools only open to white children and different schools for Black children, different restrooms, waiting rooms, demarcated spaces. This really robust structure of racial segregation impacted all aspects of life, including healthcare. American hospitals and clinics segregated patients by race. The American Red Cross separated blood donations based on a person's race. And many doctors refused to treat non-white patients and were supported when they chose that. So to give you a sense of just how harmful this system was, I'll offer one example. In 1931, a Black woman named Juliet Derricott was driving from Nashville, Tennessee to Georgia. And at the time, she was a dean at the historically Black college, Fisk University, and she was traveling with some students on a school-related trip. Now, at some point on this drive, the car got into a serious accident, and Miss Derricott and another student were critically injured. They were taken to a nearby hospital, but since the hospital only cared for white patients, it refused to admit these two victims, despite how serious their injuries were. So Ms. Derricott and the student were instead taken over 60 miles to the nearest hospital that accepted Black patients. But they never made it. They died on their way to the hospital. Now, this story wasn't unique. Through the 1960s, Black Americans who got sick, who needed medical treatment, found that it was difficult to impossible to do so, whether the nearest hospital was a block away or 100 miles away. Non-white patients who showed up in need of care were routinely turned away. And in many tragic instances, this made the difference between whether a patient lived or died. Now, let's say you were lucky enough to find a hospital that took you in. As a patient, you probably wouldn't be seen by the best doctor or placed in the best wards. Instead, your hospital bed was likely in the basement or in a broom closet. And for many non-white patients who were sick, this process of getting medical treatment included these humiliating experiences of being treated as second-class patients. This is what healthcare looked like during the Jim Crow era of racial segregation. This was a defining feature of the American healthcare system. When we add on the specific experiences of men and women when it came to their reproductive health, we find more examples of how older policies and ways of viewing certain groups as inferior, second class, undesirable, continue to shape healthcare experiences today. There's a long history of men and women suffering from reproductive injustices. Indeed, part of the field of reproductive medicine has its origins in experiments on enslaved women. And it's important for us to look at this history so we can understand just what is at stake in current debates over reproductive rights and justice. A lot of what we're facing today is the legacy and shadow of the eugenics movement of the early to mid 20th century. Now, this term, eugenics, it comes from the Greek word eu, meaning well, and gen, meaning born. So at its heart, it's this idea of being well born. And as a scientific idea, eugenics aim to improve humanity through selective breeding. This meant that if you had desirable features, if you had features that were seen of value, you should be encouraged to have children. You should have as many children as you want. You should go on and continue to have a family. While those who maybe had less desirable features should be discouraged or even prevented from having children. Now, the idea that society values certain traits and kinds of people more than others wasn't new. But what was new was that science was providing an explanation and a mechanism for achieving this vision. Eugenicists claimed that this new science could put an end to certain diseases that were hereditary. It could help raise the average level of intelligence in the US. It could even cure social problems by reducing the number of poor people, by reducing the number of criminals in society. So again, let's bring this back to people. What were the consequences and implications of this idea of eugenics? To see how it impacted individual lives, we can look at the case of a 17-year-old in 1924 named Carrie Buck. She's pictured here at the bottom. Now, Carrie Buck was placed in an asylum in Virginia, and she had been raped and given birth to a daughter. But despite these circumstances, Carrie was determined to be feeble-minded. This was a category of mental unfitness. And she was also seen as being sexually promiscuous because she had this daughter. And officials at the asylum where she was held pushed to have Carrie sterilized to prevent her from being able to have more children in the future. And their case, this Virginia case, it worked its way all the way through the courts, making its way to the Supreme Court. And in a nearly unanimous decision, the Supreme Court, the highest court in the country, upheld the Virginia authorities' decision to sterilize Carrie. She became the first person sterilized under this new law. And the Supreme Court's upholding their decision is significant because it really, it paved the way, it gave the green light for other states to establish similar laws and exercise similar kinds of authorities. By the mid-1930s, the majority of states in the US had laws allowing for sterilization operations. Now, at first, many of these programs targeted white women like Carrie Buck and white men in an effort to protect the so-called purity of the white race. But over time, people of color increasingly became the target of sterilization efforts. This included Puerto Rican women, Indigenous Americans, and Black women, in addition to people with disabilities and mental illnesses who've also been disproportionately coerced into sterilization. From the late 1920s through to the mid-1970s, over 60,000 people were sterilized under these laws without their full understanding and without their consent. And some of these sterilizations occurred while women were under anesthesia, while they were in labor giving birth. Many of these individuals were patients in healthcare facilities. They were in asylums, they were in hospitals. The doctors, the nurses, the medical authorities who did these procedures argued that they were doing so in the best interest of these people and their families, and that they were acting in the best interest of the state. This period of legal sterilization also overlapped with a 40-year study that the United States Public Health Service ran in Tuskegee, Alabama from 1932 to 1972. And in this study, health officials recruited 600 poor Black men, one of whom is pictured here on the slide. About 400 of these men already had the disease syphilis, which at the time was a major public health issue. And around the other 200 men were controls. They did not have syphilis. Now, the men who were recruited into the study were told that they were going to be treated for this disease, when in fact they were just being monitored, they were just being studied, and no effective treatment was ever given to them. Scientists and health officials simply wanted to know what happened when syphilis progressed through the body. What organs, what systems did it affect? Did the disease look different in Black people compared to white people? This was part of the experimental design underlying this 40-year study. And as a result of simply monitoring and watching and never intervening, never giving treatment, 1/3 of the men died of untreated syphilis. But another devastating consequence of this study that doesn't get talked about as much was that many of the wives and the children and the grandchildren of these men ended up being infected with the disease as well, as a result of officials allowing it to go untreated in this community. So here are at least 3 generations of poor Blacks whom health officials knowingly allowed to suffer and die from a venereal disease that by the mid-1940s had a proven effective treatment. Now, I want to talk now about what people and communities have done to expose these injustices and advocate for change. Many of us have been taught that the civil rights movement of the 1950s and the 1960s was a hard-won campaign waged to end racial discrimination, to end Jim Crow segregation, and disenfranchisement. And a lot of these campaigns focused on securing voting rights, on desegregating public spaces like schools. And although it gets less attention, the fight for healthcare was also a critical part of this movement. This was a fight that Black doctors and nurses and hospital workers waged in order to be able to train and provide care in equal settings. And through the demands that they be treated with respect and with dignity, Black people, Indigenous people, the poor, the working class, all agitated to have healthcare be accessible to all, regardless of race, regardless of gender, and regardless of income. Indeed, it's been through the campaigns waged by patients, waged by medical students, waged by the Black women hospital workers who worked in Charleston, pictured here. These are the efforts that have been the driving force in changing the way medicine is practiced, the way medicine is taught, and how it is regulated. Now, the term reproductive justice emerges a bit later in the 1990s, coming out of the work of Loretta Ross and other women of color who were responding to this longer history of reproductive oppressions and violations. And the principles they developed articulated a framework that would protect future individuals and families from similar violations, from similar intrusions and harms. And reproductive justice has as its core 3 primary principles: the right not to have a child, the right to have a child, and the right to parent children in safe and healthy environments. So here's a set of statements that really force and push us to see how matters of reproduction and healthcare are not just medical issues. Instead, the rights that reproductive justice activists are calling our attention to, are fighting for, are trying to secure, are not just about access to competent care or compassionate care, but also about the social determinants of health that can allow one to make the decisions in their best interest. And as reproductive justice activists also point out, the ability of poor women, of women of color, of people of color to exercise their reproductive rights remains constantly under attack. Many people continue to believe that women should not have children while they receive public assistance or are in public care, whether it's hospitals, whether it's prisons, whether it's ICE detention camps. And it's important for us to remember the legacy of these healthcare structures, these programs, and the ways that they have, are supported, are maintained, and are dismantled by the votes we cast and the lawmakers we support. Thank you.
Thank you, Dr. Morgai, for that fantastic talk. This was really interesting, and I'm sure that we're going to have a very stimulating discussion afterwards. So now I would like to present Mrs. Haven so that she will address some of the more contemporary issues regarding reproductive justice.
Thank you so very much. And thank you, Doctor, for that amazing presentation. I was making notes actually for things that I want to follow up and actually kind of include in what I'm talking about. My name is Kimberly Haven, and I am the Director of Policy Advocacy and Outreach From Prison Cells to PhD. I'm also on the steering committee for the Unlock Higher Ed Coalition. And more germane to today is I'm also the Coalition and Policy Director for Reproductive Justice Inside. Reproductive Justice Inside is a Maryland-based organization that works to address the reproductive rights, justice needs, and access for incarcerated and formerly incarcerated women and girls. I kind of come by this work, this intersection work of voting and education and reproductive justice because of my own lived experiences. When I was formerly incarcerated and I lost my right to vote, which is what kind of propelled me into becoming a voting rights advocate, writing the very first voting reenfranchisement bill in 2007 for Marylanders that reenfranchised conservatively about 50,000 citizens. Since then, we've made some significant progress in reenfranchising others to where we have a bill right now that is, it merely says if you're incarcerated on a felony conviction, you cannot vote. Other than that, you can vote. And so tying that in with why reproductive justice and education are so critical is that the rights that we have are so under attack. And I understand that there have been a couple of these sessions that have talked about voter suppression and things that are going on that way. But I think that what is really pivotal to me is what's happening in our country right now and the full-fledged and unabashed attack on our reproductive rights is scary at best. We are in a position to do something about that. And I think that education, and certainly those that are involved in STEM education, certainly have a role that they can play. And I've got a couple of slides that I'll go through. So please bear with me as I share my screen, and I hope that I'm going to share it effectively. So this is reproductive justice inside. We work for reproductive rights, health, and justice for all Marylanders. And what reproductive justice is. We are a statewide coalition advocating for increased access for quality sexual and reproductive health care for women and girls in all of Maryland's correctional and detention facilities. I'm not sure why this isn't in a full screen, so please bear with me. What is reproductive justice? It is an intersectional theory, strategy, and movement founded by women of color to work against reproductive oppression, the exploitation of women, girls, and others through their reproduction, labor, and sexuality. It also considers how race, class, gender orientation, ability, education, geography, immigration status, and other factors impact and determine reproductive futures. Reproductive justice is about having the freedom, as you saw from the slide a few minutes ago, that it is about having the freedom to make decisions about our bodies throughout one's lifespan, including if, when, and how to grow our families, and the ability to parent in good health with safety and dignity. And this came out of Sister Song, the mission of which is to strengthen and amplify the collective voices. And so we've built on this here in Maryland, and there is a growing movement to look at reproductive justice issues, certainly for incarcerated women and girls, but also how it plays out not just for incarcerated women and girls, but when they come home back to their communities where the rights are even more in peril for Black and Brown communities. The right to vote is a reproductive justice issue. And reproductive justice required, why is not working? Reproductive justice requires that we center the people most affected in our fight for justice and listen to the issues they find most pressing for their communities. And through, it's not a coincidence that communities that are disproportionately impacted by barriers to, say, abortion access, or through coverage restrictions on healthcare, through mandatory delays and other policies that are currently in play, are also those communities that experience the greatest number of voter disenfranchisement. At a time where reproductive rights face an existential threat from nearly all levels of government, voting can help ensure a future where all women have access to the reproductive health care that they need. I could read all of these slides. I'm not going to. You all probably read faster than I do. But the discriminatory practices such as voter ID laws and citizenship proof and other means that are being employed to suppress the vote limit people's access to the ballot. And the people that are most impacted by restrictions on voting rights are the very same people most affected by anti-abortion laws, targeting specifically people of color, low-income individuals, LGBTQ community, young people, and immigrants. And so when I said earlier that the right to vote is a reproductive justice issue, it is imperative to recognize the right to vote where voter suppression and lack of access intertwine to undermine the dignity and power of a large part of our population. the effect of disenfranchisement and reproductive rights. So disenfranchisement has two effects. One is it removes people from the political process, and then it denies them a voice on matters that directly to their lives. And this was why I got into this fight, to be perfectly honest, because without having that right to vote, without having that voice, then we don't have the ability to make the decisions about what our lives look like, our right to if, when, and how we want to have a family, and how to certainly parent with dignity in safe and healthy environments. And if we look to what's going on contemporarily, we're now concerned about the fall of Roe v. Wade. This is coming front and center, and it is a conversation that has far-reaching and very dire implications for those of us, I'm sure that's not anybody on this call, but that are as old as I am. I remember before Roe v. Wade was passed, I remember what women had to go through, and the fact that Roe v. Wade in my lifetime could then be overturned is beyond chilling. And so now the question has become, will SCOTUS uphold reproductive rights? And with the push right now to push forward for a new Supreme Court justice, we are in a very dangerous and very perilous time. And so what's at stake? If Roe v. Wade is overturned, more than a third of women of reproductive age would lose access to abortion care. That's over 25 million women, including 4.3 million Latina or Hispanic women, 3.5 million Black or African American women, over 800,000 Asian women, and nearly 300,000 American Indian or Alaska Native women. So to kind of come back to the STEM piece, why reproductive justice is an education issue. So right now, there's a move to, for instance, in Maryland, to make sure that comprehensive sexual education and access to menstrual hygiene products is being made readily available to all school-age children. But larger reproductive justice also demands that students have what they need to prevent unintended pregnancies, which would also go to increasing their chances of graduating. To acknowledge that women, and particularly women, will opt out of or not even get involved in STEM subjects because it is often seen as uninspiring or confusing or irrelevant. But STEM education has the opportunity to approach how it is delivered in a very different way that builds on the individual's prior knowledge, experiences, and ways of building and knowing in their communities, which I think is kind of, the term that we use a lot is collective efficacy, which is involving people in the best interests of their neighbors and their neighborhoods. And so STEM can play a very big role in that, in understanding how social injustice is often overlooked, but recognizing the lived and complex reality that students who are involved in STEM education are already innately motivated to resolve and to build upon changes that they want to see within their own communities. So while STEM can be effective in closing opportunity gaps, it also has the opportunity to illuminate and resolve social injustice, which would then broaden its impact. So students can come to understand social injustices within their local communities, and using those STEM knowledge and skills, they can act upon those understandings and drive the change. STEM students then gain introspective understanding of the world they live in order to be agents of change to transform within it. So if we look now at sort of like voting rights, our rights are at risk. Our reproductive rights, our access to healthcare, our access to voting and ballot boxes, our education, LGBTQ rights, our economic security, housing, disability rights, our ability to live freely and fully. At this point, and with this, and this sounds really dire and really hard, but it is no less true, that virtually all of the rights that we have taken for granted, all of the rights that protect us, all of the rights that we come to rely on are at risk. Decisions about reproductive health care are personal, and we ask that people vote their voice, vote like your life depends on it, because it does. At the end of the day, everything that we are doing is in fact becoming attacked. It is no longer becoming a safe space for us to have our opinions, to have the things that we want to enjoy in our life, the things that increase access to healthcare for all of our communities are definitely coming under attack. And at the end of the day, this is a big concern, because what we do to the people that we have incarcerated, what we do to the people that are in underserved and poor communities is what plays out. And that has a very deep societal impact on all of us. And so when we talk about women and girls that are incarcerated, for instance, you know, abortion, I said earlier that abortion access and abortion care was going to come under attack. While it is a protected right in Maryland, and we will certainly see more and more people coming into Maryland in order to gain the abortion health care that they want, incarcerated women and girls are routinely denied access to abortion care. And so if Roe v. Wade falls, it will just give state officials another reason to continue to deny them a right. So why should we be concerned? Why should we care about all of this? And how does voting kind of tie into all of this? So the doctor was talking about, you know, Carrie Buck and, you know, what happened to her. And we've just started seeing what happened in Georgia with our ICE detention facilities, and women having hysterectomies that they didn't understand what was being said to them, if anything was being said to them. They didn't give their consent. And so we can't fight what we can't see, and we can't see what they don't show us. And so in order for us to be able to see these kinds of things, we have to vote. We have to vote in the appropriate legislators that are concerned with these human rights issues, to allow us to give the sense of dignity to all of our communities, to assure that we have access to education, that we have equal and access to resources, to the very things that we need for all of our communities to thrive, to survive. And so voting, while I had a conversation with actually I went back to school with our professor, and we were talking about why people no longer vote, why we have such low voter turnouts. And when I first got involved in the restoration of voting rights, what became very clear was multi-generational disenfranchisement. So if somebody believed that they were not eligible to vote, then knowing that voting is a learned behavior, we could not be surprised that generations believed that they were not eligible to vote. And then through all of the tough on crime bills and just mass incarceration and Jim Crow and everything else that we've done, people who have had a systems involvement with the criminal justice system do not believe that they're eligible to vote. And so if you don't think that you're eligible to vote, then you're not going to vote. You're not going to find out. You are, and then you're teaching your children that you're not going to vote. People have no faith and trust in the system, and they have no understanding that that vote, even if it's on something as simple as a school board member or a county council, you know, that weighs a lot. And so we've had to try to get really clever in how we get people engaged in understanding why the right to vote is so important, that it is in fact one of the hallmarks, bedrocks of our democracy, and why it's so important and so critical that we all get involved in the democratic process. And when you think of all of the ways that voting can play out in education, how do we vote and make sure that we have enough money to fully fund our schools, to get our schools up to code? How do we make sure that teachers actually have the money that they need to survive, and that they're not paying for their own supplies out of their pocket? How do we make sure that reproductive rights across the board are protected for every individual in our country? How do we make sure that the people that are here, that are in our ICE detention facilities, are not being subjected to hysterectomies without their knowledge, without their consent? And how do we make sure that reproductive rights are protected for those that are incarcerated, and that they're not also being subjected to hysterectomies, that they're not also being subjected to and denied the right to parent with dignity in safe environments? So I'm going to end this because I know we want to have some time for questions, and I read some of the questions that have been put in, and thank you for those. But at the end of the day, more than anything else, this election cycle is probably the most critical that we will ever face. And every single person, every single vote matters. When we say vote like your life depends on it, it does. And when you're voting, you're not just voting for your life, you're voting for the very life and core of our country, to preserve our democracy, to preserve the right for human dignity, human growth, the ability to thrive, to survive. All of the things that we want for all of our neighbors, the things that we want for ourselves, are hinging upon this election, this vote. Get out and vote. Thank you.
Thank you so much for that truly inspirational talk. It was beyond informative, and again, reiterated a lot of really critical messages. So just, I want to transition us into the discussion and the question and answer. I do want to make a note that Dr. Morgai has to leave at 12:50. So if you have any questions specifically for her, I would put those into the chat box. And I think there's an ability to upvote them so that we can make sure that we get them in. But while everyone's taking some time to enter their questions, I just wanted to pose one to both of you that we saw in the registration. And it was, in addition to voting, what are active ways that researchers and clinicians in reproductive health can correct for these longstanding history of historical injustices?
Let me unmute myself. I think that's a great question, and it both gets at the heart of the topic of today's seminar and also the forum and the audience. So thank you for those who are thinking about your role as a researcher and clinician, and in addition to the votes that you cast, what can you do sort of day to day in your work and in your training? And there are a few that came to mind in terms of correcting, addressing, bringing to light these historical injustices. The first is manifest in your participation in today's seminar itself, to educate yourself, that we have a responsibility to know, to learn, and to bring these issues to light. As Kimberly Haven really, so eloquently put it, we can't fight what we can't see, and we can't see what they can't show us. And so that effort to really kind of bring these issues to light, whether it's in other educational forums or even in publications. I think about when I read so many clinical, scientific, medical publications that have these literature reviews, and they talk about, all the studies that have been done that, relate but don't quite get exactly at what this study has done. When you're working with people, when you're working with diseases, when you're thinking about issues of medicine, public health, and healthcare, what is the history behind these larger issues? If you're looking at a disease, if you're looking at a particular group, and just in something so pragmatic as that small section of a journal article, there's room, and I've seen it in so many great places where researchers, students, postdoctoral fellows are drawing out the broader context and the broader stakes around the work that they're doing. And in doing so, it's not only an opportunity to educate and communicate within scientific and medical communities, but it's also to think deeply about, the studies that you design, the way that you're interacting with the patients and the people who are part of these studies. What does respectful care look like? Not just effective care, but respectful care. And what can clinicians and healthcare providers do to build and gain the trust of those who are coming and seeking treatment? It's not about, why have certain groups been distrusting, but what have we as a profession done that, allows them and opens them up to think that this is not a place that is deserving of my trust. And I think when you sort of frame it in that perspective, you can identify and start to identify opportunities for correcting these multi-generational suspicions, injustices, and it's really, a lack of, the issue of trust, I think, underlies so much of this work. So that's a great question.
I agree. I think it was an amazing question, and from my perspective, it was to question, to think outside of the box, to look at things that are happening. And when we hear about things, when we hear about something as egregious as what's going on in Georgia, that we look and we get involved in, why has this happened? Why are policies that are deeply rooted in racist ideologies, in patriarchal ideologies, we need to question them. We need to just not accept them. And when you start looking at research projects, which is exactly what informs the policy work. So for a policy wonk like me, I need the research. You know, start thinking about what research do we need to do to, and I hate to say it like this because I sound really revolutionary, and I really am. I'm a pain in the ass. Kick open the doors. You know, as I said, particularly corrections in any kind of closed system, they don't ever want to show you what's going on. So I can't fight it from a policy perspective, but a policy perspective, they're going to look at me and say, what's the research behind this? And so work with policy advocates to question the very things that are happening, or to look at why they're not happening. Maybe something new does need to happen. Think about what long-term outcomes are, not just short-term. So COVID is a perfect example. We don't know the impact of COVID yet on reproductive rights. We don't know children that are born right now, what their health is going to be like 2 years from now, or 3 years from now, or 5 years from now. And COVID presents an opportunity to be able to look at that research. How is maternal health impacted when somebody is incarcerated? How is their reproductive ability later in life? How is that impacted by exposure to COVID? So again, thinking outside of that to help us craft policies that will protect the rights, the reproductive rights of individuals. And also education. You know, we know that education, all programming has been shut. Everybody's in solitary confinement. I work in solitary confinement issues from a policy perspective. I know the harm that's done, but by putting people in solitary confinement. And for 6 months, we've had an entire nation of people that are incarcerated in solitary. We have no idea what those long-term implications are going to be for individuals and communities. So there is a wealth of opportunities out there for research. We need researchers to get involved and to work with policy wonks like me to help us create really strong, sound policies that will preserve rights. That was a great question.
They're fantastic answers. Thank you so much for that. Dr. Murgai, I'm going to ask a question that did come in that I think is definitely related to what you spoke about in your talk. And it's kind of a twofold question. One is, what are policy steps taken that can lower the Black mortality rate? And then a second question that's kind of related is, during the Jim Crow era, when doctors were choosing to not treat non-white patients, from your research, what have some of the lasting effects been on generations that followed them?
Okay, those are great two pair of questions. And so I'll take the historical one, the second one first, in terms of, you know, what are the legacies of this, you know, defining feature, as I said, of American healthcare, that, you know, for much of the 20th century, it existed and was run on a racially segregated basis. And that had, you know, a number of effects. We can think in terms of geography, in terms of urban and rural areas, and what it means to have, you know, to live in a place like Baltimore, where you have close proximity to a number of different kinds of healthcare establishments, and how that can look very different in other parts of Maryland. And so that is, you know, going to impact everything in terms of, you know, whether women are able to give birth in a hospital, whether they choose to give birth at home in the care of a midwife, for example. It's gonna, you know, make a long-lasting implications for everything from childhood immunizations and vaccines to the ability to get emergency medical treatment. And so, you know, spatially, you know, on a communal level, these are, you know, the effects don't just go away once hospitals desegregate and essentially kind of open up for all. But this is trauma. This is, you know, lived experiences that families have been subjected to, and you don't just, you know, wake up one day and have a new relationship with medical providers, with practitioners who, you know, if they came by, were coming by for an interest in studying or monitoring, or maybe a short demonstration project, and then they leave when the funding runs out. So, you know, it really kind of raises this broader issue of what have been the longer term structures and commitments to providing care in vulnerable, marginalized, isolated groups, and the extent to which the, you know, government officials, the medical profession has sometimes neglected and not cared to do so. So, you know, that's sort of why I started with that broader framing, just to give us a sense of, you know, this was the experience of multiple generations of people. It didn't just exist in one moment in time. And in terms of the first part of that question, what are the policy steps that have been taken or may be taken to lower mortality rates? You know, in my own research right now, I'm looking especially at infant mortality rates, Black infant mortality rates. I'm thinking about, you know, just how deadly childbirth still is for women, and why that is so, and why has it been so for so long. And, you know, again, here we can think on a number of scales in terms of what specific hospitals do, like Johns Hopkins Hospital, what certain states and counties do, and what the federal government chooses to support in its funding structures, and choosing to, you know, study and seek to intervene the role of race and racism in the way that medical students are trained, in the way that delivery of medical care is provided and delivered, in, you know, sort of working to address what we are seeing in such a robust literature, you know, that things like the race of the healthcare physician and practitioner matters, where women are getting treated matters, you know, and that it isn't just something that you can reduce down to a lack of prenatal care or a lack of education or a lack of financial resources, that it's not about, you know, what an individual mother did or didn't do that leads to a particular outcome. It's about, you know, the healthcare system is really, it's not broken. It does exactly what it has been designed and set up to do. So these disparities are not an aberration. They're a reflection of institutional policies that have just become so embedded in the way that, you know, patients and those in need of care, critical care, are treated, are viewed, and are handled as they come into these spaces.
Mm-hmm.
Thank you so much for that. I really appreciate it. I just wanted to ask Kimberly if you had anything you wanted to add to that question before we moved on to the next.
No, I think she answered it eloquently and completely. It was awesome.
Great. So we do have a couple more discussion questions, but Dr. Morgai, I'm going to give you your exit so that you can make your next meeting. But thank you so much for joining us today.
Thank you all so much. And if you have other questions or want to contact me, feel free to reach out. I'd be happy to continue the conversation. And I wish you all the best with the rest of this seminar this fall.
Thank you. So we do have a couple more, I guess, kind of overarching questions. And I think one of the ones that might be on a lot of people's mind has to do, especially in light of RBG's recent passing and her imminent replacement. What is your prediction of the future of reproductive freedom given these current events?
To say that I'm concerned would be an understatement. I think that if the Republican White House is able to push forward this nomination and get a confirmation hearing, I think that the makeup of the Supreme Court will shift dramatically. And I think that depending on what happens with our electoral outcomes, could shift that back. I don't know. But honestly, I am, from a reproductive rights perspective, I'm concerned that we're going to go back to the days of pre-Roe v. Wade, and women will die unnecessarily, needlessly, and without accountability on the parts of the role that people play in this. They're dodging questions. You saw in the vice presidential debate, Vice President Pence refused to answer the question, dodged it. And so we are concerned across the board. There will be cuts to funding for doulas, for Medicaid. There will be cuts across the board that will strip women of their reproductive rights and their reproductive access. And so that's why we really need to be steadfast. We really need to vote. We really need to educate ourselves on the issues, and then we need to be poised to act. And I don't mean that like in a, take to the streets with pitchforks, although that is an amusing idea. No, I'm saying that, in the states like Maryland, where abortion is a protected right, where abortion, we will still, our borders will be open, that, we can assist, but we already have people coming from other states to Maryland. That will expand. How do we expand doulas? How do we expand dignity? How do we make sure that women have the care that they need? That's what I mean by being poised to act. Don't take to the streets with pitchforks, just saying.
Thank you for that. And given the fact that our next seminar is actually going to be on immigration, I found this question pretty interesting. It was asking, how can we ensure that reproductive rights are granted for all people in the U.S., including poor individuals as well as non-citizens? It really seems like that is, especially with what was discussed in as far as language barriers and the ICE detention camps and everything, that's a very important question that needs to be addressed.
Well, we've kind of talked about the poor communities. Let's look at the immigration piece, because that is very, very problematic. ICE detention facilities are run by the federal government. And so while there could be states that have, that maintain ICE facilities, they're getting money from the federal government to, keep them incarcerated. So they're also not subject to state oversight. So while we wrote several bills here in Maryland that also applied to ICE, we had to strike that from our bill because the state can't mandate federals. And so trying to get information inside ICE detention facilities is virtually impossible. We have to work through attorneys, and attorneys try to get information out, and it's not until we have a whistleblower that, like the lady in Georgia, the nurse in Georgia, not the lady, the nurse in Georgia who came out and said what was happening, we had no idea. We can suspect all we want, but we now need to, this is a perfect opportunity to galvanize people to say, what we do to people that we have within our care, custody, and control is what they're going to take back, whether it's to their community, to another country, to whatever. But if we believe that people that are incarcerated in our ICE facilities are less than American citizens, that are less than, and we give permission for that treatment, to give a woman a hysterectomy when she doesn't understand the language, when you're using Google Translate to try to explain to her what's happening to her, what's happening to her body without her consent, how dare we? And so ICE is going to be something that we absolutely need to close ICE facilities. We need to demand that advocates have the ability to go in and talk to these people, to hear what's happening to them, and then to be able to advocate, but also to hold people accountable for the treatment that, that they're receiving at our hands.
Are there any, I guess, out of everything that you said, what would you say are the first steps in achieving those goals?
Working with federal legislators to make ICE open the gates. Because again, we can't fight what we can't see, and we need to be able to get in there. And we need to be able to go in there unannounced, whether it's a legislator and an advocate, an attorney and a legislator, somebody has to be able to get in there unannounced. Because we do the same thing in prisons. If there's a prison tour, you'll see people outside, they're painting the curbs and they're putting cute little flowers out just to show, everything is great. We treat people with dignity and respect. Yeah, we know that's not true. And the same thing is true within our ICE facilities. They need to be able to roll up unannounced and do an audit. And the people that are running the facilities need to make their records open for inspection and action. And that's going to take federal help. The state can't do it.
Thank you. That really did answer a lot of questions that I know I had, and I'm sure that the audience had as well. And so we'll just take one more question in closing. I think that this is kind of more projecting into the future. What do you feel as though is the most important what are the most important reproductive justice issues that we are currently facing, and or do you anticipate us facing in the next 2 to 3 years?
Preserving access to abortion care, not criminalizing women for pregnancy loss. When a woman goes into, for instance, into an emergency room and she has a substance use disorder, the police are not called. I am fearful that we are going to start seeing more of that criminalizing for pregnancy loss behavior across the country. But I also think that we need to work to just preserve reproductive dignity for all citizens in Maryland and across the country, to ensure that women have the appropriate, the dignified, the compassionate reproductive health care that every woman deserves.
I agree, definitely. We really appreciate you taking the time to come and speak with us. This was a fantastic seminar. I know that there are many people who are interested in knowing how to be able to continue the discussion. And so I just want to, I guess, just highlight a little bit the fact that we do have the Johns Hopkins Science Policy Group here for people who are interested in getting involved at the campus level. There's also a reproductive justice group here on campus, and I figured, Kimberly, you might be able to chime in as far as the organizations that are in Maryland that people can be able to get involved in.
And I would be happy to talk further with anybody that's on this call or anybody that's interested in this, either through solitary confinement, through reproductive justice, through higher education in prison. You know, I wear multitudes of hats. All of them seem to also, you know, intersect with Johns Hopkins, and also because I'm a policy wonk. So I would love to talk to anybody. So, you know, please reach out to the organizers of the event. They have my contact information, and I would love to continue the discussion with anybody who's interested in any of these work.
Thank you so much. That's really great. So as she did say, if anybody has any additional questions or wants to get involved, please feel free to contact us. And again, we have everybody's information and would love to continue the discussion with you all. So just as a reminder, the election is forthcoming. And so just to reiterate, if you have any questions about the format for voting or the registration deadlines or anything, a lot of that information is available currently on our Johns Hopkins Science Policy website. There are links that basically walk you through what it is that you need to do to be able to get involved. And please join us for our seminar next week, which will focus on immigration and immigration rights. So thank you all very much for joining us today. I hope everyone enjoyed it, and I hope that you all have a fantastic weekend.
Thank you so much.
Yes, thank you.